spent all morning inundated with a curriculum review for my course. So if you're ever wondering the pains that your instructors go through, it's far beyond just getting up here and talking in front of everybody. This is like the easiest part. Actual creation and modification of a course is very laborious, and I don't enjoy it at all. I would much rather talk. But say la vie. This afternoon we have a lecture on neuro-ophthalmology and some conditions related to neuro-ophthalmology. This is usually some of the more difficult material to try and comprehend and learn, so just do your best. I'll try to make it as simple or relatable as possible. And then tomorrow, I believe we have a lecture in the afternoon. That's the last major lecture where I'll teach you stuff. And then Wednesday, we have a lecture also in the afternoon. And that's going to be the review lecture for the test, which I believe is on Friday. Do you have any tests between now and Friday? Oh, sweet. You guys are going to pay attention to me? Yeah. That's exciting. Okay. Any questions before we get started? All right. Here's what we're going to cover. Conjunctivitis might be an errant bold. I don't think we're going to have any conjunctivitis on here. We will talk about optic neuritis, papilledema, and more on amaurosis fugax as well. Okay, these are the topics we're going to cover. We'll talk briefly about the visual pathway. Again, I don't expect you to be experts on it. That's what they have the experts for. But I think it's important to know kind of what's happening with vision. We'll also talk about the pupillary pathway and then some conditions that you can get when things go wrong. Okay, so some terms to start with. When we're thinking about the visual pathway and sight itself, typically we don't want to have any blind spots in our sight, right? That's not a good thing. But if we do, we kind of classify them based on how much vision loss there is. So the first term, hemianopia, is essentially a loss of a hemisphere of your vision. So in stroke patients, if you have a stroke in the visual cortex in the back of the brain, typically you lose an entire hemisphere of your vision. Whether that's the left hemisphere or the right hemisphere, you're going to lose half of your visual field, which is problematic. Okay. Then the next term is homonymous. That means the vision loss is on the same side. So if you have a stroke again, you lose the same side of your vision. So if you have a stroke in the right visual cortex, you lose your left visual field in both eyes. So it's going to be medial in the right eye and lateral in the left eye. Okay? That's on the same side. If you have a tumor in your pituitary gland, that's going to crush the optic chiasm, and then you're going to have heteronomous visual field loss. So you'll have what we call bitemporal visual field loss. It's on the opposite sides, heteronomous. Okay, so homonymous, homo, same. Homonymous is the same side visual field loss. And again, if you have a hemianopsia, you're losing an entire hemisphere of your vision. Ipsilateral, kind of like homonymous, vision loss, it's on the same side. Contralateral, it'd be opposite, so it'd be like heteronomous. And then the scotoma is a fancy word for a blind spot. In anisocoria, chorea means pupil, aniso is unequal, so anisocoria is an unequal pupil size. Okay. All right. So we talked a little bit about the optic nerve already and the retina. Talked about how there's a lot of photoreceptors in the retina. We've got rods and cones. Again, rods help you see at nighttime. That's your motion vision, your black and white vision. And those are located mostly in the peripheral retina. And then cones, there's far fewer of them. Those are located centrally in the macula. Those allow you to see your crisp, clear 20/20 vision, and cones also are associated with color vision. Okay, you've got some other types of cells in the retina called ganglion cells. Those help transmit the signal to the brain. Shouldn't have to worry too much about ganglion cells though. Okay, and then when you have visual field loss on the optic nerve, kind of goes along with the nerve fibers when they're in the retina. All right, so when the optic nerve head inserts into the retina, that is called the disc, okay? And again, remember with glaucoma we measure the cup to disc ratio. This is kind of what the nerve looks like when it's inserting into the back of the retina there. And then this is the visual pathway, okay? This is kind of a daunting diagram, but if you think about it and look, I'll try to make it make sense. Okay, so light enters an eye. Let's just focus on the left eye right here. Okay, light enters in this left eye. There's a split of the retina, and we classify the temporal retina and the nasal retina. Okay? And there's nasal fibers and temporal fibers that run through the optic nerve. So the temporal retina has its own set of retinal fibers. The nasal retina has its own set of retinal fibers. Okay, temporal retinal fibers stay on the same side of the brain the whole way back to the visual cortex, as you can see diagrammed here. Same side for temporal retinal fibers. Nasal fibers will actually cross or decussate here at the optic chiasm. Okay, that's pretty important. Nasal fibers cross at the optic chiasm and then cross over to the other side of the brain, the contralateral side. Okay? And then everything ends up back here in the visual cortex. So all of that light signal will come in through the eyes, go back to the visual cortex, and then your brain transmits that light signal into what you actually see. And that's the visual pathway. So again, if you don't like diagrams, maybe you like words, the optic nerve takes both the nasal and the temporal retinal fibers back to the chiasm. And again, at the chiasm, that's where those nasal fibers cross over or decussate. The temporal fibers stay on the same side. And then after the chiasm, you've got what we call the optic tract. And that tract has temporal fibers from the ipsilateral side and nasal fibers from the contralateral side. Okay. So both eyes are, or both sides of the brain are going to be stimulated in the optic tract. Okay, there's a portion of the brain called the lateral genicular body, and that's where you have actual nerve fibers entering that part, the LGB, and they kind of leave as these fibrous radiations. Okay, not super important if you're not a neurologist. The visual cortex is pretty important though. That's again the part of the brain where the visual signal is transmitted into what you're actually seeing. And again, you've got both eyes being represented in the visual cortex because those nasal fibers split. Okay, that's words. Now we're going to go on to a really trippy diagram. This one, unless you're on LSD, probably isn't going to make too much sense. This one is real trippy, but it's essentially the same thing as this diagram right here. Okay. Now we're breaking it down into superior and inferior visual fields, nasal and temporal fibers, but you can still see that the nasal fibers cross here at the chiasm, temporal fibers stay on the same side. It's just trying to break it down more as far as your superior and inferior visual field go. I don't care that you know all that much, but in case you do, there's a diagram for you. This one is real nice. This is some sweet clip art here. Okay. This is again trying to demonstrate the nasal and temporal visual field. I did not make this. Okay, so we can have visual field defects at any point in the visual pathway. Okay, so any part of the visual pathway can become damaged and you can get a visual field defect. And the cool part about visual field defects is typically we can actually figure out where the visual field defect is in the pathway just based on the actual defect itself. Okay, so this chart and the words are describing different types of visual field defects. So if we look at number 1, okay, we have an optic nerve head lesion, an optic nerve lesion. So this left nerve right here, there's a lesion right there. And the right eye, you can still see, is seeing fine. The left eye is black. Okay, so one of your optic nerves has a lesion on it. You're not going to have any vision out of that eye. The whole eye, both nasal and temporal fibers are going to be not working. Okay, and that's what number 1 demonstrates. Number 2 is demonstrating a lesion at the optic chiasm. And typically, a pituitary adenoma is going to cause this bitemporal hemianopsia here. Okay, so you can see both temporal fields are not working because there's a lesion in the chiasm. Why would it be bitemporal visual field loss at the chiasm? Because what's crossing? Because the nasal fibers are being compressed here. So that if the nasal fibers are being compressed, remember you see opposite. So your nasal fibers are actually what provide you your temporal vision. So if your nasal fibers are compressed, you're not going to have any temporal vision. You have bitemporal hemianopsia there. Okay? That's number 2. Number 3 is going to be some sort of lesion in the optic tract here. And this is going to be an incongruous visual field defect. So it's not going to be the same. It's still on the right side. You've got a right visual field defect, but you have more of a right visual field defect in that left eye than you do in the right eye. That's just because of the positioning in the tract. Okay? 4 looks like there's a defect at the lesion, at the nerve, okay, in that right eye. So the right eye is blacked out. The left eye still has a little bit of vision from the nasal retina because the temporal fibers in that left eye are still firing. And as you work your way back, you can kind of understand where the visual field defects are taking place just based on where the lesions are, okay? Do I expect you guys, as PAs, to understand really any of this? Absolutely not. What you should understand, though, is if a patient doesn't have a full visual field, something is wrong, okay? As long as you punt it to ophthalmology or optometry, you'll probably be okay. So just recognize visual field defects do correlate to some place in the brain. You probably will never need to know exactly where the visual field defect is taking place, okay? Unless perhaps it's like number 1. Number 1 is pretty easy, right? There's damage to the optic nerve. The patient is blackout blind then. Okay? We'll talk more about lesion 1. That's going to provide what's called an afferent pupillary defect, an APD. We'll talk about that in a little bit. That's going to be important for you guys to understand. Everything else, not that important. Okay, now we're going to move into the pupillary pathway. Different from the light pathway, a little bit, but pretty similar, okay? So everything I just told you relates pretty well to the pupillary pathways. Now what do we mean by pupillary pathways? Well, when we shine light into your eyes, we expect the pupils to constrict a little bit, right? That's normal. So we've got 2 main pathways, the afferent or sensory pathway. So what I tell my students is to write afferent equals sensory equals cranial nerve 2, afferent, sensory, cranial nerve 2, and then we have the efferent pathway or the motor pathway. So efferent, motor, cranial nerve 3. Okay, you can have damage to both the afferent and the efferent pathway. If you have damage to the afferent pathway, we call it an afferent pupillary defect, or an APD. If you have damage to the efferent pathway, we don't call it an efferent pupillary defect, we just call it a third nerve palsy. Okay? All right. So again, this is just talking about how the pathways run and that decussation again. All right, here's a picture diagram of the pupillary pathways. Again, very similar. Okay, you've got nasal and temporal fibers again. Nasal fibers cross, temporal fibers stay on the same side. So if you shine light into one eye, into this left eye right here, both halves of the visual cortex are going to be stimulated because those nasal fibers cross over. All right, we're going to talk now about an afferent pupillary defect. Sometimes it's called Marcus-Gunn pupil. Typically, it's just called an APD, afferent pupillary defect. I think you guys learned this as a RAPD. Do you guys learn RAPD? Or do you learn strictly APD? RAPD. So RAPD is a relative afferent pupillary defect, which is probably more typical to what you're actually going to see. You're not going to see a full APD typically. We don't oftentimes differentiate between APD or RAPD. If you see any sort of pupillary defect, APD, we just call it APD. But an afferent pupillary defect is damage to that sensory portion. So if you think an afferent pupillary defect, if you see one, something's wrong with the optic nerve, the second cranial nerve. Okay? There's damage at the optic nerve. So when you shine a light on a normal eye, when you shine a light into this left eye here, that sensory signal is going to go back on the afferent pupillary pathway, all the way back to the visual cortex here. That's all the afferent pupillary pathway back here. The brain then is going to say, I've got a bright light being shown into my eyes here. I need to constrict my pupils. It senses that, and it's going to send a motor signal back down, but it sends a signal through both eyes. Okay, so both pupils will constrict when you shine a light into one eye, because those nasal fibers crossed and both sides of the visual cortex are stimulated here. That's normal. Okay. So shine a light into one eye, into the left eye, both pupils should constrict. Okay, let's say there's damage to this left eye here. Let's say there's a lesion right on this optic nerve here. Okay, so I shine a light into this eye. There is no signal getting back to the brain. Therefore, there's going to be no constriction of either pupil here. Okay, that makes sense? Now if we swing the flashlight over to the right eye here, there's no damage on the right eye, so thus both pupils should constrict. Okay? Left eye, no constriction in either eye. Swing it over to the right, both pupils will constrict. Then when we swing it back to the left eye, because there's still an APD or a lesion here on the second nerve, both pupils will redilate to what their normal state is, because there's no signal getting back to the brain. Swing it back over to the right, both constrict, back over to the left, both dilate. Okay? They're not dilating like when you get dilating drops put in, but when you go from a position of constriction and you open back up, technically that's called dilation. Okay? So that, in a nutshell, is what an APD is. Damage to the optic nerve, there's no signal getting back to the brain, there's no sensory signal getting back there. So if there's no sensory signal getting back there, there's not going to be any motor signal being sent back forward. All right. So again, when you're examining for an APD, you're going to do the swinging flashlight test. So you're going to hold the light in front of one eye, hopefully both pupils constrict, swing it over to the other eye. In a normal person, both pupils are going to stay constricted throughout the swings. Okay? If at any point you have redilation of both pupils, then you have what's called an APD, afferent pupillary defect. Okay, this picture is kind of demonstrating what I just said. Okay, so you shine a light into this patient's right eye, both pupils constrict, you swing it over to the left eye, both redilate. And that patient has a left APD. Taking up a mild APD, and this is where we'll say a mild APD, we'll call it like a relative APD. This is the RAPD. Okay. You have a slight constriction, but it's not a full constriction, so the pupils are going to redilate a little bit, just not fully. That's a RAPD, relative afferent pupillary defect. Okay, and these conditions can cause an RAPD. But if you have a severe APD or a full afferent pupillary defect, something then is wrong with the optic nerve itself. Okay? You have no sensory signal getting back to the brain. All right. When you have an APD, sometimes you may have anisocoria if the pupil sizes are unequal. You don't necessarily need an APD to have an anisocoria. There are other conditions that can cause anisocoria or unequal pupil size. Sometimes you're just born with unequal pupils. And if the pupil size is the same, whether you're in light conditions or if you turn all the lights off and you measure pupils and you're in dark conditions, as long as the difference between the pupils is the same in light and dark conditions, we don't really worry about that all that much. Okay? So, for example, if you're born and you're in light conditions and your right pupil is a 5 millimeter diameter, your left pupil is a 3 millimeter diameter, when you turn the lights off, if your right pupil becomes a 7 and your left becomes a 5, that's still a difference of 2 millimeters in light and dark conditions, so that difference is the same. And then we call that just a physiological anisocoria. Okay? Many people have this. Okay, where we get concerned about anisocoria is when the difference is different in light and dark conditions. Okay, so again, if you have that 5 millimeter in the left eye and a 3 in the right, when it's light out, and then you turn the lights off, and then you've got a 7 and a 4, now that difference isn't the same, and that's called pathologic anisocoria. So some disease process is making that anisocoria come to light. If you don't know why the patient has a pathological anisocoria, punt, okay? Probably to ophthalmology, so they can figure out why a patient has pathological anisocoria. All right, we're going to talk about a few conditions that will create a pathological anisocoria. And the first is 80s tonic pupil. Okay, so the way I remember 80s tonic pupil is that sluggishly silly young ladies get 80s. Okay? Sluggishly silly young ladies get 80s. What do I mean by that? The light reflex with 80s tonic pupil is sluggish or slow. Okay? Silly because the damage is actually in the ciliary ganglion in the brain. Young ladies, because usually this happens to young ladies, and they get 80s. Okay? So if you're doing pupil testing and you see one eye responding normally and the other's real sluggish or slow, consider 80s tonic pupil. Okay? So the EOMs will be normal on these patients. They probably won't have a ptosis either. Okay? This could be idiopathic. Sometimes it's inflammatory. And if you see this and you want to confirm it, you can instill 0.125% pilocarpine in both eyes. But if you do see this in clinic, what I would recommend you doing is punting. Okay, so somebody else can confirm it. All right. Here's a picture of somebody with 80s. This is a young lady. She has 80s. Okay. So you can see in the picture here, her left pupil is dilated compared to the right one. She's got an anisocoria. And if you're in light conditions, this anisocoria is going to be more asymmetric. Okay? Because that right pupil is going to constrict more than the left one does. All right, next we're going to talk about Horner syndrome. Okay, Horner syndrome, little Jack Horner sat in the corner with his ptosis, meiosis, and facial anhydrosis. That's Horner syndrome. Little Jack Horner sat in the corner with his ptosis, meiosis, and facial anhydrosis. So this is a classic clinical triad with Horner syndrome. And the reason it happens is we've got sympathetic pathway damage. Okay, so sympathetic pathway again is that fight or flight response. Okay, we said a few things happen with when the fight or flight gets triggered. Okay, your eyes are going to open a little bit wider because which muscle is being activated in the eyelid?
Oh, left.
Not the levator. That's controlled by the third nerve. There's a Mueller's muscle. Very good. Mueller's muscle is also in the eyelid. That helps to open the eyes. It's innervated by the sympathetic branch of the nervous system. And so when you're excited, Mueller's muscle will fire and that opens your eyes up really wide. Your pupils dilate when you're really excited, okay, because your body wants to see everything that it possibly can, so it's going to open your pupils up. And then typically you'll start to sweat as well when you're in the fight or flight response. Okay. So if your sympathetic pathway is not working, Mueller's muscle is not going to fire, so you're going to have a mild ptosis in that eye. The lid is going to be a little bit lower than the other eye. Hey, again, sympathetic pathway is not working, so you can't dilate the pupil, so it's going to be constricted relative to the other pupil. And then you're not going to be sweating on that one side of your face either. You'll have facial anhydrosis. If we have a picture. There's a picture on the internet of a female that has Horner syndrome, and it's a really good picture of the facial anhydrosis. She just got done doing yoga or some workout, and one side of her face is red, like flushed, like she just got done working out, and the other side is not. It's pretty pale. And that's the facial anhydrosis. And so the side that's pale is the damaged side, because it's not able to sweat on that side. Okay. There's several causes for Horner syndrome. Okay, could be congenital though. And there's a way to diagnose it with cocaine. We don't typically use that in office. Cocaine is not readily available for us to put in patients' eyes. Okay, so we can see there is an anisocoria here. Okay, the pupil sizes are irregular. Okay, that right pupil looks a little bit larger than the left one. You probably appreciate the ptosis on this guy. That left lid is definitely down. This guy doesn't look like he works out all that much, so you can't really appreciate the facial anhydrosis, but I'm sure it would be there. Okay, same on this guy. That left pupil is constricted. There's a bit of a ptosis there as well. That is also Horner syndrome. Ptosis, meiosis, facial anhydrosis. All right. Last one we're going to talk about is dirty Argyll-Robertson. Why is Argyll-Robertson dirty? He has syphilis. Not just any syphilis. He let it fester, and now it's become tertiary syphilis, neurosyphilis. So he has damage in the brain due to syphilis. Okay. The pupillary defect that you're going to see with Argyll-Robertson pupil is actually that the pupil just doesn't respond to light at all. Okay? So you shine a light into this patient's eye, they're going to have no pupillary response. Okay, so it responds either real slow or not at all to light. But when you have the patient look at something up close, the accommodative reflex to that pupil is still present, so their pupils still will constrict, only with a near response. We'll call that light near dissociation. So the light reflex isn't present, but they do still have a near reflex. And that's indicative of Argyle-Robertson pupil, and this guy needs to get his syphilis treated. Probably has other issues, but he does have pupillary issues as well. Okay, this is a picture of Argyle-Robertson pupil. Okay, looks like that left eye is slightly more dilated than the right one. Okay, but it still would respond to a near reflex. All right. Off of anisocoria, now we're moving on to papilledema. Papilledema, you can break this word down. Edema is obviously swelling. Okay, papil is relating to the optic nerve. Okay, so if you have papilledema, then you have swelling of the optic nerve. And this will show in the back of the eye as an elevated optic nerve head. Okay, it's going to be pretty swollen. The important thing to remember about papilledema is it's a bilateral condition. So if you have bilateral optic nerve head swelling, or optic disc swelling, you have papilledema. If it's just one disc that's swollen, it's not papilledema. It has to be bilateral optic disc edema. And that's indicative of elevated intracranial pressure. Okay. This can be caused by a mass or pseudotumor or idiopathic intracranial hypertension in your younger females. Okay. Something's wrong with them. This patient's going to have visual issues. Their vision's going to be usually not very clear. They're going to have distance vision acuity issues and also peripheral field issues as well. Okay, so somebody with papilledema with elevated intracranial pressure is going to have a headache, and it could be nauseous, could have amaurosis fugax, transient vision loss, tinnitus, diplopia, all sorts of bad things. Something's wrong with this patient, okay? So again, the signs that you're going to see are bilateral optic nerve head swelling. Okay, you might see bleeding cotton wool spots. Again, consider pseudotumor as a cause, the idiopathic intracranial hypertension for papilledema as well, if you have a younger female. Okay, this is what a swollen optic nerve head looks like. If you recall what a normal nerve looks like, typically it's supposed to be that donut with the hole in the middle. You can't really appreciate the outsides of the donut here. And this is harder to appreciate, the swelling on a 2D image like this. But if you use your context clues, you can kind of see that there is elevation here. So follow the path of the blood vessels. Normally this blood vessel would just be straight, but it's kind of elevated because it's sitting on that elevated disc there. Excuse me, you can see some of that elevation on this blood vessel here as well. And again, true papilledema is going to be bilateral. So the right eye is going to look like this, and the left eye is also going to be swollen as well. Okay, this picture has some bleeding associated with it as well. Okay, same with this picture and this picture. But again, if you have true papilledema, both the right and the left optic nerve heads are going to be swollen. Bilateral optic nerve swelling, papilledema. Okay, sometimes if you have increased intracranial pressure, some of these smaller cranial nerves will become cut off just due to the pressure inside of the eye, or inside of the head rather. So the sixth nerve is one that is susceptible to ischemia due to increased pressure because of the way that it runs in the head and how small it is. It can become compressed pretty easily. And you can get a sixth nerve palsy. You remember the sixth nerve only does one thing, controls lateral rectus, very good. Which does what? AV ducts, very good. So if you're having this patient look in their right gaze, they're able to abduct with the left eye here, but they're not able to abduct with the right eye. So there's a sixth nerve palsy with this patient. All right. So for papillodemas, the workups that we're going to do, we always measure blood pressure first. Okay. Have to measure blood pressure, and then we're going to do an MRI with contrast. And we're looking for a mass or a hemorrhage. Okay, and then we need to relieve the pressure somehow, but we can't just do that right away. So you have to do blood pressure, then an MRI, then you can do the lumbar puncture to relieve some of that pressure inside of the brain. And then you do neuro, and then finally an ophthalmology consult. Okay, that's a specific order for what you need to do for papilledema workups. Okay, and how do we treat papilledema? Got to treat whatever's causing that elevated intracranial pressure. Okay, so if it's pseudotumor or the idiopathic intracranial hypertension, weight loss or acetazolamide are useful. Okay, this is probably one of the more common ways to get papilledema is with pseudotumor. Okay, so again, we're thinking of that obese female who's usually in some sort of childbearing years. I saw one female with this when I was in my 4th year externship. She fit the bill. Like, she was overweight. She had papilledema, okay, bilateral optic disc swelling, and had no masses inside of the brain. So she ended up losing weight, and the swelling went down. She did lose visual field though, okay, because when that nerve is swollen like that, that's going to cause essentially like a glaucomatous visual field loss on her, and that again is irreversible. But she ended up not having papilledema, so there's no further loss after that. All right. Okay, next we're going to cover. I talked about giant cell arteritis already. I mentioned it. We're going to kind of dive into giant cell arteritis, which is also called ischemic optic neuropathy. Okay. We've got 2 types of ischemic optic neuropathy. You can have arteritic or non-arteritic ischemic optic neuropathy. Giant cell arteritis falls in the arteritic ischemic optic neuropathy. Okay. So an AION is also giant cell arteritis. NAION is not giant cell arteritis. Both will have some sort of ischemia to the optic nerve. And obviously, if you have ischemia to the optic nerve, that's going to be bad. You're going to have vision defects, and you can have optic neuritis as well, but not bilateral. Okay, just single optic disc swelling. Okay, again for giant cell arteritis, GCA, also known as an arteritic ischemic optic neuropathy. Typically, this is your 60-plus-year-old male patient. Unilateral swollen optic disc. So if it's just a unilateral optic disc, it's not papilledema. Okay? Something else is wrong with the patient. It's not papilledema. All right, if you have somebody coming in with unilateral optic disc swelling, not papilledema, definitely at the top of the differentials should be giant cell arteritis. You need to run labs with this patient. ESR is very important to run for a patient with suspected giant cell arteritis. ESR. Also CRP and basically the full blood panel. But ESR is going to be elevated with giant cell arteritis. Okay. They'll also have firm temporal arteries. Okay, they'll be firm, so if you palpate on the temporal aspect of their face, they'll have firm arteries. And then the way that they conclusively diagnose giant cell arteritis is they'll do a temporal artery biopsy. So they'll take a slice of the temporal artery, put it under the microscope, and look for those giant cells. Okay, giant cell arteritis is going to have sudden painless vision loss though. Okay? Headache, eye pain, jaw claudication is going to be something that is typically only talked about with giant cell arteritis. So you see the word jaw claudication, jaw pain, pain when chewing. Typically we're thinking giant cell arteritis, okay? Jaw claudication. Scalp tenderness, all the other things listed. Jaw claudication is the word I would highlight there. Okay, you can see this nerve is kind of swollen. Okay, it doesn't look quite as bad as papilledema pictures, but this nerve is still swollen. Kind of those feathery edges on the nerve, it's not well defined or circumscribed. And this is a patient that has giant cell arteritis. How can you tell that this patient has GCA just by looking at the nerve? Trick question, you can't. Okay. I know it is because that's what the slide says, but if you show me this nerve, all I know is that is a swollen optic nerve head. Okay. And then I'm running through. Is the other swollen? If it is, then they have papilledema. Okay. If it's not, now we just have single nerve optic head swelling. What other symptoms does the patient have? Do they have jaw claudication? Okay, they probably have giant cell arteritis. That's how I've run through those things. But if you guys can at least appreciate, this is not a normal looking optic nerve head. A+ for me. Okay, now we're going to talk about non-arteritic ischemic optic neuropathy. Still sudden painless vision loss. Okay. So not really a way to differentiate between GCA or the arteritic versus non-arteritic just by the vision loss. They're both going to have sudden painless vision loss in an eye. And again, if I show you this, how do you know it's non-arteritic? You don't. Okay? You don't really know. You need more context clues. Okay, so you're going to order the same labs, ESR, CRP, but you're not going to have the elevated ESR with the NAION. That's the main difference. You're going to order the labs. Labs are going to come back fairly normal with an ischemic optic neuropathy. Okay, so this slide kind of sums it up. How do we treat them? GCA, we're giving that patient steroids to reduce that inflammation. And the NAION, we're kind of just observing to make sure that everything returns back to normal. Okay, prognosis, if you have GCA, not a great prognosis. You're probably going to have severe vision loss in that eye. Usually that's permanent as well. NAION definitely has a better prognosis. Okay. So the main differentiator between these two is the labs. ESR is elevated, CRP elevated. We're thinking GCA. If not, call an NAION. You're hoping for the latter. All right, moving on to optic neuritis. Okay. Optic neuritis is also called papillitis. So again, papil, we're thinking optic nerve head. Itis is an inflammation. So this is just an inflammation of the optic nerve head. Optic neuritis. Okay. You can have swelling with optic neuritis, but it's not bilateral swelling. It's just one eye. Okay, interestingly enough, optic neuritis is often the first sign of multiple sclerosis. Okay, so patients will come in to the eye clinic, a lot of times complaining of vision loss in an eye or decrease of vision in one eye. We'll take a look, it's swollen, and if it's a female in a certain age demographic, we're oftentimes punting over to you guys to confirm MS. Okay. It's not the only way you can get it, it's just one of the more common ways to get optic neuritis with MS. Okay, there's always variations to where the inflammation is happening. whether it's right posterior to the globe or on the disc. Sometimes it can be in the retina, the nerve fiber layer itself. But the symptoms are going to be very similar: unilateral vision loss, okay, hours to days. You'll have pain on eye movement with optic neuritis. Think about it, that should make sense. The optic nerve is inflamed, and anytime you move the eyes, the nerve is also moving, so that's going to be painful for that nerve. Okay? Pain on eye movement, transient visual field defects, headaches, tenderness on the globe, and sometimes they'll spontaneously recover. Okay, more signs. Usually average age of 30 years old. And again, if it's MS, typically that's in a female. You can have disc edema if you have an optic neuritis. It's not bilateral, again, because that would be papilledema. But you can have some disc swelling. Otherwise, we're just concerned about the pain on eye movement. Similar workup to almost everything else we're going to do related to the optic nerve: full eye exam, MRI with contrast, and then any labs that you need to order. Okay, here's a picture of optic neuritis. And again, if you're just looking at that one eye with zero other context clues, you have no idea that that's just optic neuritis. Okay? You want to look at the other eye, see if the other eye is swollen, inflamed. You want to rule out, based on what type of patient you had, if it's GCA or NAION, or if it's just optic neuritis, and then treat accordingly. Another picture. So this is some of the imaging that we're going to see. You can see that left eye is lit up. Okay, that would be the retrobulbar optic neuritis there. That left optic nerve is very inflamed. How do we treat it? Depends on the cause. Okay, if it's MS, you treat for MS, and hopefully that will help. If it's another cause, infectious, non-infectious, just treat the actual cause of the optic neuritis. Okay, you guys love your charts. Here is a chart for you. All right, we talked about amaurosis fugax already, transient vision loss. Okay, could be a clot or plaque that's blocking the central retinal artery. Okay, if that happens and it dislodges, then it's amaurosis fugax. If it doesn't dislodge, then you have a central retinal artery occlusion. So we're hoping that you just get amaurosis fugax. Okay, this is a picture of a plaque. You guys see where the plaque is? And here's an arrow. And there also, looks like there might be a little plaque right here as well. This is where that first plaque is. Question? Okay. Okay, you can see these plaques lit up under fluorescein angiography as well. I have 14 slides left. Do you want to take a break or do you want to punch through? Okay. Third nerve palsy. Okay. Talked about this already. We could consider this an efferent pupillary defect, but there's so much more happening when you have third nerve palsy, so we call it third nerve palsy. Third nerve controls a lot, controls several EOMs: superior rectus, inferior oblique, medial rectus. Also the levator, that muscle in the eyelid that elevates the eye, and then the pupillary sphincter as well. Okay, so if you have the third nerve palsy, we talked about this already, your eye's going to sit down and out because the lateral rectus and the superior oblique are the only muscles that are actually working. Everything else is paralyzed. You'll have a ptosis because the levator is not working. And then sometimes you can have a dilated pupil, a blown pupil. You don't have to have a blown pupil to have a third nerve palsy. If you do have a blown pupil with a third nerve palsy, that is an emergent situation because it's probably a brain aneurysm, unfortunately. But other things can cause a third nerve palsy. You can get a tumor, severe diabetes can cause third nerve palsy, many things. All right, droopy eyelid, ptosis, eye that's down and out. Okay, patients are going to have obvious visual symptoms and obvious visual signs. Okay, they're gonna have double vision. New onset double vision is a great cause for concern. Something is definitely wrong with the eyes or the brain. Okay. And again, if they have a dilated pupil with the third nerve palsy, that is bad. Okay. You need to rule out a brain aneurysm with an MRI. Pictures of the third nerve palsy, you can see that left eye is down and slightly out. Pupil doesn't look like it's blown though, which is good. The patient does have a ptosis that you can see. Okay, what do we do for a workup? If the pupil's involved, order an MRI. Okay. If the pupil's not involved, then you just need to treat it by fixing whatever is compressing the third nerve. If it's severe diabetes, get the diabetes under control. If there's a tumor, resect the tumor, and hopefully everything goes back to normal. Question?
Yeah. Why is it an MRI instead of a CT?
It's a great question. I don't have a great answer for you. You'd think if it was stat, you'd want something that was a little faster than an MRI. Which is what the book said. I don't know if the MRI provides perhaps better views. Maybe that's a great question though. I don't have a great answer. You'd probably be fine with the.
Stroke stuff is all the CTs.
Yeah, you'd probably be fine ordering a CT as well. Some sort of head imaging, whether it's CT or MRI. Don't order an X-ray. But yeah, you'd be fine. I think with either one of those. It's a great question. There's probably a theoretical answer that I'm just not familiar with, but you'd probably be fine ordering either. All right. Okay, fourth nerve palsy now. This is again damage to the trochlear nerve. This is not super easy to diagnose, and patients are often not very symptomatic to this. Obviously, you have a little bit of double vision if you have fourth nerve palsy. And patients will compensate a lot of times with that double vision just by turning their head. Okay, so if someone's walking around like this, they either have a kink in their neck or they've got a fourth nerve palsy. And that torsional aspect that the superior oblique controls is not working. So to compensate for that, patients will just turn their head so that they don't have double vision anymore. Several ways to get this. You could just be born with a fourth nerve palsy, trauma, or severe diabetes or hypertension, or a tumor. Any sort of compressive disease could cause a fourth nerve palsy. Okay, so again, objects may be tilted, so the patients will just tilt their head to compensate for it. Okay, so the contralateral shoulder, they'll tilt their head towards. So if they're tilting this way, then it would be the right fourth nerve that's not working. If it's tilted to the right, then it's the left fourth nerve that's not working. Do a MRI, or just punt them to ophthalmology if you're suspecting a fourth nerve palsy. How do we treat it? Treating the underlying disorder. Sometimes we can put prism in their glasses as well to try and correct, so they don't have to walk around like this. We can adjust where the light is entering their retina to try and alleviate that head tilt. Okay, here's a fourth nerve palsy picture. Right. So in their primary gaze and their left gaze, the patient's right eye is elevated just a little bit. If you're looking at that center picture there, you can see the right eye is slightly elevated. Okay, because the superior oblique does intorsional movements as its primary job, but then also aids in depression. So if that right eye can't depress, it's going to be slightly elevated. So the patient's going to tilt their head to the left to try and alleviate some of that double vision. All right, we talked about a sixth nerve palsy as well. Okay, so if a patient can't abduct, they have a sixth nerve palsy. This one's going to be pretty easy to see. And we're thinking some sort of vasculopathy is causing this sixth nerve. Could be some tumor or intracranial pressure, but a lot of times it's just uncontrolled diabetes that causes a sixth nerve palsy. Horizontal diplopia is going to be the obvious sign and symptom for the patient. Okay. I remember I was going to tell you guys about Jordan Groff, and I forgot when I was talking about lecture. Jordan Groff is an ophthalmologist, pretty great one. He's a retina doc. I shadowed him again during my externship in optometry school. And I tell you guys this so that when you're shadowing in ophthalmology, you don't repeat my mistakes. I was shadowing Dr. Groff while he was doing a very in-depth procedure. He was going to take a patient's intraocular lens out. So the patient already had cataract surgery, had the IOL put in. There was something that was not right with it, and then they had retinal issues as well. So he went in, took the IOL out, which takes a long, long time to do, and then went into the retina, and there was a little membrane that was growing on the patient's retina. So he was going into the eye with this tiny little forceps and peeling this microscopic membrane off the patient's retina. It was like a 45-minute to an hour procedure, which in eye care is really, really long. And I was told to pick somewhere to stand and just observe. So I did. I didn't pick a great spot, and I didn't have great views, and I can't just stand in one spot for that long. So I ended up kind of walking around the backside of the table where he was operating to try and get a better view. Found a better view, it was great. And then he caught my movement out of his peripheral vision, stopped what he was doing, told me to freeze. And I was like, oh shit. And then he promptly told me that I should never move around while he's in a patient's eye because it's distracting to the surgeon, which makes sense in the long run. I felt kind of bad because I could have caused that patient damage if I would have made him freak out. And then he educated me after he closed the patient back up as to why I shouldn't do that. So, long story short, when you're observing any surgeon really, just kind of pick a good spot right away and then don't move unless they tell you to move. That's my Jordan Groff story. This guy also, I think he was LDS and did a mission in South America, and it's like a white dude from, I think he was from Iowa. Spoke the most fluent, like Telemundo host Spanish. It was insane. We would talk to the patients. We were in Phoenix, so there was a heavy Hispanic population down there. Man, it was really fun to listen to. Not when he was telling me. All right, this is a sixth nerve palsy picture. Okay, you can see that there is a defect in the patient's left eye there, left sixth nerve. Okay, how do we treat it? Fix the underlying problem. If it's from uncontrolled diabetes, fix the diabetes. If it's hypertension, fix the hypertension, and hopefully the sixth nerve will start working again. If it doesn't, we can always put prism in their glasses or help them with strabismus. All right, that's all I got. Any questions? One more lecture. I'll see you tomorrow.